All right, guys. We're not talking hockey today. All right, today we're talking hand and wrist. Not my favorite subject, but we have with us Dr. Rosie Sender.
Hi, YouTube. That's my favorite subject.
Yes. So Oklahoma, guys. What happened? So John Mateer, what exactly happened with this? Can I use your hand?
Sure.
Yeah, excellent. Okay.
You might want to use this one.
You know, I don't want to make Charles jealous, though. You know, like, I don't have Charles' hands, but, maybe we can introduce, what's his name?
So...
It's okay. Don't worry about it.
I do not name my model's hands. I will just make that clear.
And I think I broke this.
Yeah.
All right, so what exactly happened? So he's throwing the football, right? Mm-hmm. And he goes like this. Mm-hmm. Boom! Yeah. And then, yes, right there.
Right.
Boom,
right.
Boom, ow. That hurt. So what do you think happened?
So there could be many things that happen, right? We don't know for sure. We don't know the exact injury. That wasn't reported. But if I were to guess, it was probably one of the more common hand fractures that we see. And I'm thinking that it might have been the base of thumb metacarpal fracture. And the reason I think that is that, again, usually these happen if you have a little bit of a load to the thumb in a flexed position. I know you're not that interested in hand fracture. But this is a favorite subject of mine, so let's try to.
So it's not this. What you're saying, it's not this. So
No.
His hand didn't look like this, right?
Look like this.
Right. So this would be what? That's like CMC, right? That's carpo-metacarpal. But you're talking about this bone, metacarpal.
I'm talking about the first metacarpal,
Yeah.
which is this bone. And it does articulate with this bone down here, which is called the trapezium. And so actually, what's really interesting about this particular joint, which is a CMC joint, is that it's called a saddle joint. And it is a very, it's a joint that's very mobile. Being very mobile, though, it's also very prone to injury and instability. So it's such a common fracture that we see.
Interesting. So when you say saddle,
Okay.
no.
Try to make this as goofy as
We have very different interpretations.
He'll cut it out. It's okay.
It's all good.
So, so essentially what can happen is the impact here, like even when I did that, that hurt doing that.
Course.
So if he broke it, and he broke it at the base, say in the middle, say wherever.
Right.
Let's say it's undisplaced.
Okay.
Does it matter that it's in the joint, in the middle of the bone, or at the end of the bone?
Well, any fracture that's anywhere near the joint or crosses the joint line, it's actually pretty serious, right? Because you can't have even more than a millimeter of displacement. It will actually change the mechanics of how that joint works.
Right.
Right.
So if let's assume this. Let's just take this all apart. Let's assume that this is a joint. Let's assume this is a metacarpal, right? So this is nice and smooth, right?
Exactly.
So if you break this, you have it offset, right?
Exactly.
Should I bring my chisel out? Shall I break it? I don't think we have time. Filming! So essentially what happens is instead of gliding smoothly, it'll be like offset.
Absolutely.
Right.
And then once that happens, you start to get abnormal wear patterns on the cartilage.
So the cartilage is more than a millimeter. So whatever is smooth, it's kind of like a rut in the road.
Exactly.
Right?
Exactly.
We blame the government for all the roads, right? Well, if you get an injury, you got a rut. Now imagine riding a tire over that.
Exactly.
And you're just rolling back and forth.
And you start at wearing...
Scoring the cartilage, wearing the cartilage.
Away.
Right.
And then that ultimately predisposes to getting arthritis. And obviously that ends up with limited mobility, pain, stiffness,
Right.
not a good place to be. So we
Right.
try to restore that joint line as close to anatomically possible as
Okay.
Yeah.
So we don't know all the details about the type of hand
we don't
fracture.
know.
So again, educational series, we're using
Speculation.
injury as a topic for discussion. Now, let's assume it's extra-articular. So that's outside the joint. And let's assume, could it be at the base or in the middle? Does it make a difference that it's extra-articular at the base? Like, is it more likely to displace if it's an oblique fracture versus a straight, or is like some people like to say, clean fracture, a clean break. So are there opposing forces in the muscles and the kinematics of the thumb?
Absolutely. One of the more common deforming forces in the thumb is the abductor pollicis longus, and it basically inserts onto the base of the thumb on the dorsal side.
So which would it be? Which one is it?
So basically, well, you're not going to be able to see it on your wrist, but basically I can show it here a little bit more. So it's going to be on the dorsal radial side at the base, right? And so what will happen is
there's these two here. So which one is it? Is it this one?
It's going to be on this side.
Right. Yeah. So it's over here.
Yeah.
Right. Okay.
And then so basically what will happen is that it'll pull that shaft down. It'll proximally and dorsally and radially. Right, so that would be the major deforming force on that side.
Can I break this hand?
Please don't. That's my
Can I break the broken hand?
Yes, you can.
Okay, so let's assume. Oh, this is. Hey,
that caused me a slight trauma.
Well, that's okay, because there's bone glue out there. If anyone knows, I mean, someone patented many years ago, but they finally made a commercial product of bone glue, so we can just bone glue it.
Okay, sounds good.
But this is fake. We can use crazy glue. So anyway, okay, so let's assume that this is the fracture. Don't worry, I will fix it.
Okay, fine. I also know. Okay.
All right, so let's assume this is the fracture, right? Mid-shaft, right? Mid-shaft, relatively clean break, right? So what would you do with this?
So what's actually been exciting in the last little while is that we would have to fix this because that would be a very unstable fracture. And
the pattern, yeah, like show me what would happen with the thumb with the opposing forces here. Would it go this way?
It would go this way.
Oh, yeah. So like that.
Yeah.
Oh, not good.
Yeah.
Okay.
So basically the different ways of fixing these fractures are, doing either percutaneous pins or doing plates with screws or internal screws that act as struts in the bone. And what you choose depends on what's the most biomechanically stable construct, right? What's exciting now, and what I've been doing lately for these shaft fractures is the internal strut screw, right? Like it's a screw that you place inside the bone.
Intramedullary.
And it actually allows for faster rehab and less tendon complications, because what can happen is you can get a tendon adhesion to any plates and screws that you place on there, right? So more scar tissue. It's minimally invasive, so we don't have to make big incisions, less dissection. So we can.
So it's like a screw, but similar to what sometimes people have had a rod in their tibia. Like femur fractures, tibia fractures, you get rods. In this case, you're actually putting a screw that's threaded that compresses the bone together and lines it up. I was looking, I don't have a model for that, but basically imagine like you put an I-beam inside the column. So you know how columns in homes, they just have a little exterior facade, but the beam is on the middle. Imagine that your bones don't really have the beam in the middle. That's what we're putting in. Well, that's cool. Okay, so if you didn't do that, you would put what? Screws, plates, screws, or bone glue.
Or bone glue. I have not.
It's not. I don't think it's available yet.
I don't think so either. But yeah, so if it was a straight transverse metacarpal shaft fracture, I probably would put the intramedullary screw in.
Okay.
It's become my sort of favorite go-to method of fixation for those type of fractures.
So let's assume this is fixed.
Yes.
What's he gonna do? Let's assume it's a relatively clean break. It heals up, minimally invasive intramedullary surgery. What is his expected? Let's not specifically say this is in Matir's case, but in general, when you have this, what's the splinting, what's the rehab, how quickly will he progress, and then the later question is, what is the likelihood of when he'll be back?
Right. So here's the thing. Anytime we fix a fracture, we have to protect it for a period of time while it heals, right? So, first couple of weeks, you're in a thumb spica splint, and this is a splint that will incorporate the thumb so that there is no movement occurring at the thumb, give it a chance to heal. I usually convert patients to thumb spica casts after a couple of weeks of splinting. And then, at about 4 weeks, we convert to a thumb spica brace. So at that point, we can start then we can start rehab. And this is
So is it 6 weeks of immobilization?
So here's the thing, it depends on the fracture pattern. There are certain fracture patterns where I will start early in like gentle range of motion exercises. Say I would even start it at 4 weeks if it's stable enough and I know I have good fixation, and if I trust the patient as well as the therapist to proceed with caution, but just get some gentle range of motion started. So it's all very individual. But if it's a little bit more serious fracture pattern, or there's more instability risk, or the fixation may be a bit more precarious, then I'll sort of say, hey, let's just do it at 6 weeks, okay? But a lot of times I do like to start some early mobilization so that we don't have stiffness as a problem.
Right.
This is a PSA to everybody, so this isn't just athletes, this is to everybody, and I say this to every single patient that I have, is that surgery is part of the process. Rehab is probably one of the most important parts of recovery. And so surgery could be done perfectly end to end, but if you don't do that rehab, then getting back that motion, getting back to your usual activity, that can be impaired. Now, I'm assuming Mateer is going to have the best therapist in the world, right? So,
well, it is Oklahoma.
I still feel that he probably has access to the best.
Do you think the Oklahoma fans will be annoyed with me?
I think they'll love that comment.
They'll love that comment?
Yeah.
Okay, we'll keep it
I
in.
support you, Oklahoma. I support the hand therapists of Oklahoma. So anyway, I feel, so basically what will have to happen is that he will need to do very progressive hand therapy exercises. First, working on the mobility of the thumb to get that range of motion going, the flexibility going, and then they ultimately move to strengthening.
Right. And so that's the important part, is that there are phases of rehabilitation. Now, obviously, he's not a pro athlete yet, right? He's Oklahoma University athlete, but he's progressing in that direction. So it's not like he has a multi-million-dollar contract and there's insurance, and also
He actually might.
he might have a
Because
contract.
of NIL.
Well, no, right. I was gonna but in terms of NIL, it's not to the same level. Well, actually, it might be quite a bit
As a
nowadays.
rookie, he's probably going to make more now than he would as a rookie.
Yeah, interesting.
He's making money.
He is making money. That's true. But he doesn't have. Okay, all right. Slightly different way of making money. That's true. Okay, so in the athlete who's not pro, and nowadays, actually with NIL deals, they're actually making money off of this. So could he lose some of that? I don't know. That's not my area of expertise. If you talk about a multi-million-dollar pro athlete with a contract, there is insurance, maybe he doesn't get his bonuses and stuff, it matters. But athletes are challenging, right, to treat.
Yeah, absolutely.
They're wonderful patients. They have great biology for the most part, unless they smoke. Unless they smoke, right?
Yeah, exactly.
Yeah, okay. So great biology, great healers, but they want to get back in the game.
That's it.
They push you to say, I want to go now. When can I play? When can I play? When can I play? So 6 weeks, he gets through that.
Right.
He's rehabbing, he's moving. He's at, let's just call it 5-10 pounds of strength.
Okay.
Is he ready to play?
Again, I would probably say not, just given the risk factors of re-injury. And you can also, when you don't have full mobility, say you still have some stiffness, and you hurt that same area again, you can cause a different type of injury too, right? So it's what. But again, I'm not. I'm a little bit more risk averse when I treat patients, so
Right.
I tend to be a little bit more careful when I feel people are truly ready to get back out there.
And Clay Thompson was the best example.
Right.
Hamstring, Achilles, ACL, all of those things. So you go back too early, you have a little bit of stiffness, you
Yeah.
go to the wrist,
Yeah.
maybe you hurt the shoulder.
100%.
Right.
Like anything could happen.
Anything
right?
could happen.
And so we see this all the time in our our practices, but it's very understandable the pressures that the athlete's under, right? It's not just the athlete wanting to get back, it's the team, it's the owners. There's just a lot of extra stress.
So let's say he does everything right. 6 weeks of healing, 6 weeks of rehab, he's getting his strength back. Are we looking 3 months? 6 months?
Typically,
Best case scenario.
it's the best case scenario. He's healed well. His strength is
To throw a football
Yeah.
in contact sport.
yeah, and he's able to do that. Then 3 months is early for sure, but I think with athletes they might be able to do that, right? I think 6 months is probably typical for the average person,
Yeah.
realistically. But here's the thing: we all recover a little bit differently. So, I would also leave it up to the therapist's discretion as well to sort of see how are they doing in therapy? Look at some objective evidence, right? Objective
right.
metrics to see do they truly have their strength back? Do they truly have their mobility back? Right? So it's not just a feel
individualized.
thing,
Yeah.
right?
So it has to be individualized.
Yeah.
Working with the trainer, the therapist, and one of the important things. I mean, he's at Oklahoma, one of the greatest colleges. Well, we'll call it one of the greatest colleges. Come on. Anyway,
Look, I respect Oklahoma. I respect the fans.
I respect Oklahoma.
I do not share the same sentiments of my colleague.
Cut. Again, I mean, not necessarily a pro athlete, however, high level playing.
Yes.
So he's going to have access to a lot of tools. Like,
Right.
like we're talking special cold therapy, we're talking
Sure,
special
right,
tools,
yeah.
regenerative technologies,
Right.
all sorts of different things.
Yeah.
What are some of the things that a player like him would have access to that someone, even like me, or grandma across the street, or everyday person wouldn't necessarily have access to?
Well, I think here's the thing. I will say that in the world of, hand surgery, hand rehab, there isn't anything above and beyond what you would do for any other joint, right? So I think he will be seeing hand therapists who are very specialized OT hand therapists, right? So they will make custom braces for him and adjust as necessary, but they have multiple therapeutic modalities at their disposal to help his mobility, help his strengthening, any issues with sensitization. There's multiple things that they can do. So he will likely be seeing a hand therapist, right? So and then beyond that, whatever other sports injuries, athletes use alternative modalities, like you said, regenerative therapies,
Cold plunges,
TENS,
heat,
TENS,
ice, all of
everything.
those things.
So I wouldn't say that it's any different than for
Right.
I
think the difference would be is the frequency and the access that's available, right?
That's why I said, again, they would want to see a hand therapist who is a specialized type of occupational therapist, right? So they have a different level of training. So it's not physical therapy, it's OT hand therapy, right? So that will be the difference. And then what we normally recommend for the average person is twice a week. So maybe you said, maybe it's a little bit more often in the week. And, more guided recovery.
More guided recovery. And again, a lot of times we're limited in the everyday with payers, insurance, and how many sessions. I mean, it's very common, and we've discussed this before. It's kind of like the authorization of insurance is, oh, you're authorized for 6 sessions,
Right,
12
right,
sessions. What is any of that meaningful? Like the number of sessions has nothing to do with recovery.
No.
It's just
It's very,
a way of insurance companies monitoring their pocketbook, right?
Well, exactly, because again, it comes down to it's very individual.
Right.
And it's dependent on the person. It's dependent on the fracture pattern. It's dependent on the type of surgery. There are so many.
And the
factors
recovery, the tempo of recovery varies.
Exactly.
Everyone's different.
Everybody's different. So
Yeah.
again, it's very individualized, right?
Right.
So when we are in clinic and we ask for a certain amount of therapy, we already have an idea based on the injury pattern, based on the type of surgery required, based on the patient, that whether somebody's going to have a prolonged recovery period, they're probably going to need a little bit more than the average person.
Right.
Some people actually don't need as much, and we'll ask for that. And you're right, insurance limits on how many therapy sessions you can prescribe.
Or the timeline, by the
timeline,
time you get
exactly.
authorized and approved.
Yeah.
And, access to regenerative technology. Are there various cutting edge technologies for fracture healing, recovery, soft tissue strength, mobilizations,
And again,
all of those
that's
things.
actually an important
Yeah.
point. There are certain regenerative therapies where I feel it might have augmented a patient's recovery, but again,
It's not accessible. It's too expensive.
It's too expensive for the average person, but also increasingly they are denied by insurance.
Right.
So I can't necessarily, but a player like Mateer will likely not have those kind of issues, right?
Right.
Will be able to pay out of pocket if necessary, and I don't know.
Right.
I don't know what the insurance is on that side, but I feel for him, he will be able to access all the different types of
All the best treatments,
modalities,
therapies,
to
get a
him
second
out there
opinion if
quickly.
he needs,
Exactly,
all of that. Yeah.
exactly.
So, and then the other topic that was brought up was and again, this goes to how often he's seeing the occupational therapist. I mean, you're talking about the thumb spica splint to a brace to a custom orthotic. I mean, custom in the insurance world means a lot more. So off the shelf versus custom. So he may very well have access to some of the custom,
Yeah.
or they may 3D print something, or they make it
Absolutely.
truly
Yeah. And again,
customized and changing it every week.
Yeah, and the OT hand therapists usually, again, it depends on the OT hand therapist, but they make the custom molded braces themselves. And really, what it is, it's this thermoplastic splint. So when you warm it up, you can mold it just right so that
Right.
it fits the patient well, and it's easily adjustable. If, for example, you go away for a while, it doesn't quite fit right, you just go back to the therapist, and then they just reheat it again and remold it.
Yeah.
And it's so they have the capacity of doing that in the office, right?
Right.
So that you can get off the shelf braces as well, but sometimes it is better to have something that's custom molded to
Right.
you, for the fit.
Yeah. Well, John Mateer, I know you're going to do well and heal up. I am looking forward to seeing you back on the field, as much as everyone else is, saying negative things about Oklahoma. I have nothing negative to say about Oklahoma.
I wish you a speedy recovery,
Yeah.
Sarah. All right.
So Dr. Rosie is also co-founder of our startup, Kinesi. She's the CEO as well. So, and we do have a prototype for the hand. Now,
Right.
if we were to apply a prototype of a Kinesi HandSense, wearable during the recovery and rehab phase,
Right.
one of the biggest factors is understanding the kinematics, the metrics, the recovery, all of that.
Absolutely.
That would be important. That's why we're doing this, right?
Absolutely. Absolutely. I think that will be a game-changing variable in the world of orthopedics. You can attest to this too. We make, I don't like saying guess, but we make educated guesses when somebody is back. We are doing our own assessments in our offices when we feel patients might be ready, and that will be, measuring their range of motion, using, like, if I'm just talking about the hand, using a grip strength dynamometer. But again, and then we're taking the therapist's reports as well, and then we're making that determination that, okay, you're ready to go back. But if we have a tool that gives us precise objective measurements, it gives you much more confidence of telling the patient when they are ready to be able to participate in whatever activity it is. And maybe we'll have a better idea. You can do this much of your activity, or you can do your full activity, but it'll give us more objective measurements, which would be amazing.
And so, and these metrics, like, and here's the key, right? It's real world metrics. So he's going to be wearing, an athlete would be wearing this, and they're going to be doing their regular activities, their sporting activities. They're going to be wearing it for many hours per day doing the activities. And so you're going to have highly precise, highly accurate, high quality, real world kinematics in real time. And imagine if you had that before the injury. So then you have a fingerprint of motion, a true motion of that hand and thumb and finger, and then you see how it recovers afterwards, and then you can gauge it. So it's not just like the metrics that the therapist can use, that we can use, the trainers and everyone, but it's our confidence, but it's the athlete confidence too, right?
Exactly.
Because then the athlete can say, oh, this number, and we've seen it happen, right? Where they see a number and they're like, oh, okay, that's equivalent to a 75-yard punt, right? So then they say, oh, okay, I can do this. And then so it makes that mind-body connection where you have the data, the objective metrics while they're doing the activity in the real world, in practice, and that converts.
And I think we're just in a different time now. There is an expectation of having more objective and precise metrics, right, in our health. And we've seen that with all the other wearables that are out there. How many people like to use like their Oura rings or their Whoop bracelets because it is giving them information that they can use to make their performance better, or like you said, I couldn't have said it any better, but just having that confidence of where they're at or what they need to do to just get that extra bit of performance. Right. So that currently doesn't exist
to that level.
And we're trying to take it to a level of precision that no one has done yet.
Yeah, and we always talk about precision joint kinematics, and that's really the key, is that if you can have that level of information, like we're not talking about, every 10 milliseconds. We're not talking about your Apple Watch correcting or collecting data at various time points. It's billions of data points over multiple minutes and hours of information that's all calibrated using software we built, hardware we built, and shout out to Manu Chatterjee, our CTO, who helped and built our devices and software. And that's what will really be game changing. So then we can say, not only our confidence, but even the athlete, he can look at his own data and he can say, okay, I see what you're saying, doc, and I feel, based on the numbers and how I feel playing, that when I'm reaching closer to this number or closer to this metric, I'm feeling I'm ready to play. That's the confidence we're giving back.
And there's also the ability of the athlete, the doctor, the therapist, the coach, the trainer, to all start speaking the same language.
Exactly.
And that currently doesn't exist.
Yeah.
So that is one of the...
And it's not a negative testament to anyone, right? We all have our own software. Everyone has their own methods and methodology. There's so many ways to train and produce the data. But I mean, we've all seen it, right? You go one patient to one physical therapist, other physical therapist, or even the same physical therapist in the same office, or trainer, or even doctor, one of our colleagues. The reports, like, you can't necessarily say what they mean, and a clinic visit is less than 0.1% of an athlete's mobility or any patient's mobility, whether it's worker, at home, whether you have you're limited at home, in your workplace, at risk for fall, or at risk for fall in workplace, in your sport. What we're doing in clinic, we do an examination, and it's our best estimate. I mean, we can't be with you all the time, but actually with Kinesi, we can.
Whether you like it.
Whether you like it or not, right? But in a good way. I mean,
way, yeah.
it's providing you the information and you the tools, the athlete, the trainer, the doctor, the therapist, everyone that is accountable for your health and wants to know about your health and your recovery.
Right.
And then you can gauge it. You know, what the surgeon may want to know or the therapist may want to know may be much deeper,
Yeah.
whereas ultimately the coach and the general manager, can he play?
Absolutely.
You know, do I need to get a backup?
Exactly.
You know,
Yeah.
so all of that garners a level of confidence in game, play, and decision making.
Absolutely.
Better data, better decisions.
I agree wholeheartedly. So I don't have anything more to add.